Good evening, everybody. Welcome to our webinar on sleep apnea. My name is Darryl Steff. I'm the CEO of Down Syndrome Australia, and I'm also the parent of a 15-year-old girl with Down syndrome. And it's a pleasure to be here with you this evening, hosting this session on sleep apnea. I will begin by doing a brief acknowledgement to country, and this acknowledgement to country has been developed by our advisory network. So as Down Syndrome Australia, we respect the First Nations people and elders from this land. First Nations people have lived on this land for many years. Now we live, work and play on this land together. We can learn a lot from all of their stories and all of their knowledge. So just to start, I have a brief video to introduce Down Syndrome Australia.
We are the voice for people with Down syndrome.
Our purpose is to influence social and policy change and provide a national profile and voice for people with Down syndrome.
I think it's really important to understand and acknowledge that our community is diverse and that we see the value of everyone. Every single person out there with Down syndrome and their families is important, and we're there to represent all of those people.
Our vision is an inclusive society where people with Down syndrome have full participation and equal access to all human rights.
To realise this vision, we focus on three things: improving the quality of life for people with Down syndrome, building capacity and collaboration amongst the Down syndrome community and our member and partner organisations, and leading change in society's awareness, attitudes and behaviours. Our work is guided by four values: inclusion, we welcome and include everyone; respect, we treat everyone kindly and value their thoughts and feelings; honesty in everything we say and do; empowering, we support people to have the confidence and skills to succeed. Throughout all of our work, we ensure the voices of people with Down syndrome are central. We work with people with Down syndrome from across the country in key roles, like health and employment ambassadors, members of our Down syndrome advisory network, and also on our board.
Ensuring people with Down syndrome have their voices heard at Down Syndrome Australia is essential. It means our experiences shape the decisions that affect our lives.
While we celebrate what we've accomplished, we know there is still more to do. Looking ahead, we continue to be committed to creating a more inclusive society, a society where everyone, no matter their differences, is celebrated and welcomed.
And I would just like to emphasize that for us, it's really important, the working relationship that we have with our state and territory associations, many of whom I know are online on this webinar this evening. Now, it's my pleasure to introduce this evening Associate Professor Jasneek Chawla. Jaz is a paediatric respiratory and sleep medicine specialist at the Queensland Children's Hospital in Brisbane and leads the Kids Sleep Research Group at the Child Health Research Centre as part of the University of Queensland. She completed her PhD studying sleep disorders in children with Down syndrome and is currently leading a valuable piece of research focused on improving the diagnosis and management of sleep disorders in children with neurodisability. Jaz is also the newly appointed President of the Australasian Sleep Association, the national peak body for sleep professionals. And personally, I've had the pleasure of working closely with Jaz for over 5 years now and can say that she is a very strong supporter of our work at Down Syndrome Australia and with people with Down syndrome more generally. So it's great to have Jaz with us this evening to inform us and educate us about sleep apnea and Down syndrome. Jaz, thank you for being with us, and over to you.
Thanks, Daryl. Thank you so much for this opportunity to present. And hopefully this will be a great webinar where I can teach you all something and learn as well myself. So thank you. I'd just like to add my acknowledgement of country on behalf of the University of Queensland and Children's Hospital Queensland, and acknowledge the traditional owners and their custodianships on the lands on which we meet, and pay respects to ancestors and their descendants who continue cultural and spiritual connections to country. We recognise their valuable contributions to Australian and global society. So I'm going to start just with a bit of background, and I think some of this will not be a surprise to those of you in the audience who've been going through this yourselves. But I'm sure you will know that sleep disorders are very common in individuals with Down syndrome, and generally they come and go through life with peaks at certain ages. So this is not something that just happens at one point in childhood or one point in adulthood. This is something that occurs all through life and comes and goes, and something that individuals with Down syndrome learn to live with. And there's lots of different factors that contribute to sleep problems in Down syndrome. The facial features associated with individuals with Down syndrome, the sort of flatter face, means that the airway is more crowded, and that can lead to a greater chance of there being obstruction. And when I say obstruction, what I mean is that the airway is crowded, and as you sleep and relax, everything kind of collapses in and you can't get the air in through the top part of the airway. There's also behavioural factors. So there's things that we know are specific to individuals with Down syndrome that really impact on sleep. We know that some individuals with Down syndrome have trouble with obesity, and that is also a risk factor for problems with your breathing during sleep. But there are also other things that are part of this condition that we're starting to learn more about. So we're starting to learn that individuals with Down syndrome have different ways in which their breathing is controlled, that their sleep and wake cycles are different. And then, of course, there are things like medications that we throw into the mix that also can impact on sleep. So what about children? And this is what I'm really going to focus on for my talk today. Broadly, we can divide sleep problems into two big categories. So we have sleep disordered breathing. So that's breathing disorders when you're asleep. And the most common one of those is obstructive sleep apnea. This is actually about 6 times more common in children with Down syndrome than it is in typically developing children. And as I've mentioned, it's contributed to by the facial features, so the flattening of the face, the larger tongue, and also the tone. So being slightly lower in tone also impacts on that upper airway collapsing down during sleep. And as I've mentioned, this can often reoccur, and it can sometimes persist even when we do the first lines of treatment, which I'll talk a little bit about through this talk. We also see what are often termed these non-respiratory or behavioural sleep problems. By that, I mean things that are not related to your breathing. So things like resistance at bedtime, anxiety related to sleep, nighttime waking, parasomnias, and that's things like night terrors, sleepwalking, sleep talking. And a really big one is restlessness. So lots of moving around during sleep. So why am I talking about sleep? Well, we know that in children with typical development, sleep has negative effects on heart, on growth, on your metabolic function, on your learning and your behavior. And for children with Down syndrome, we know that this is likely to be more, that they're likely to be more vulnerable to this. This is because these problems are really common and they come and go, sort of through the whole part of childhood. So for that reason, we're more likely to see that they're going to have impact from these sleep problems than we do in another child who perhaps just has it for one part of their childhood. Similarly, the period of development is a lot longer for children with Down syndrome. And for that reason, it's likely that they're going to be more vulnerable. So when we look at some of the little studies that have been done, we actually see that children with Down syndrome who have obstructive sleep apnea, or OSA as I'll refer to it, they actually have worse learning, so worse cognitive outcomes, worse language, and worse daily function. So we know that even in the small bits of work that have been done, that this is a real problem that we need to deal with. So the other reason to think about it is because sleep is actually one of the things we might be able to make better. And really, if we can make it better, we might actually help improve how children with Down syndrome function. And so and not just the children, but also the families. And so I think it's really important that this is something that we actually can modify, and so something that we really should address and think about for families. So we've done a piece of work where we looked at the Australian population of children with Down syndrome, and I'm sure many of you have contributed to our work. And with the help of Down syndrome Australia and Down syndrome Queensland, we sent out a survey, and we looked at children who were coming to our clinic. So that's the hospital sample, and they were coming to the sleep clinic where I work at the Children's Hospital. And then we also looked at children who were recruited through the community. And what we did is we asked families to fill out a questionnaire related to their child's sleep. And this is the questionnaire that we use a lot in research. We got them to do a medical history form, and we looked at how common sleep problems were in children with Down syndrome. Now, for this questionnaire, if you have a score above 41, it means that you have significant sleep problems. And not surprisingly, when you look at our little graph over here, you can see that these were children that are all way up here in the 60s. So this is really suggesting that there are significant sleep problems. We also asked what was the reason for the families to be sent to the clinic in the children that were coming to our clinic. And we asked in the if there were sleep concerns for those that weren't coming to our clinic. So were they worried about sleep? So these are really important facts that we found. We found that 74% of parents in the group of children who weren't coming to our clinic had concerns about their child having a sleep disorder. And none of these have been were being actively seen, and less than half of them have been previously seen. So lots of people out there were telling us that there were sleep problems, but they weren't actually having any treatment for it. And when we looked at who was coming to our clinics, it was really for snoring that most of these families were reporting being referred to the clinic. But actually, when we looked at their sleep habit scores, these were suggesting that there were not just snoring problems or breathing problems. There were actually a lot of different sleep problems going on. So what did we really conclude from this? Well, what we found was sleep problems are very, very common in both the community and in the clinic sample of children who were coming who in Australia. We didn't see any difference between those who were coming to the clinic and those who are not. And that's really concerning for us, because it's telling me that there's a lot of families out there who have children with sleep problems who are not getting any help. We also found that the focus is really on breathing, but this study actually showed us that it wasn't just breathing that's a problem. There's a lot of other sleep problems. And I'm going to touch a little bit on that, even though this is a webinar mainly about breathing problems. So what we really thought was, well, we need to try and improve awareness. We need to try and make it better for families, but also we need to tell health professionals that sleep in children with Down syndrome is something that needs to be treated. And what I just thought I would show you all is that we did put together some fact sheets. So these are 4 families, and these are on the Down Syndrome Australia website. And these are about different aspects of sleep in children, which hopefully will be helpful to some of you if you haven't seen these already. Okay, so let's focus in on the main breathing problem, which is obstructive sleep apnea that we see in children with Down syndrome. So I've mentioned some of this already, but the risk factors for obstructive sleep apnea, or OSA, in Down syndrome, there's lots of different risk factors. And you can see that on this little picture that's here. I've mentioned already the sort of flatness of the face and the nose crowds the upper airway. They generally have, children with Down syndrome have smaller upper airways. Their tone is different. They sometimes struggle with obesity as they get older, particularly. There's the larger tongue. And then there's conditions like hypothyroidism, so the thyroid problems that actually also impact on their risk for obstructive sleep apnea. So there's a lot of different issues that contribute to this increased risk of obstruction in children with Down syndrome. When you look at who should be screened and when children should be screened, there are international recommendations from the American Academy of Pediatrics that say that every child should have a sleep study, which is also known fancily as a polysomnography or PSG, by the time they're 4 years of age. And if they haven't had symptoms before that. So some children will get referred early, but if you haven't been referred, then by the age of 4, you should have a sleep study. Now, this is really challenging because we don't have enough resources to do this, but we know that this is really important. We also know that a lot of children actually need to be screened before that, and that 4 may actually be a bit late. Believe it or not, in adults, there's recommendations that you should perform screening for obstructive sleep apnea, but currently we've got no guidelines to know how and when this should be performed. What I've put here is a little flow diagram that tells you the kind of common way in which we see children route in through the sleep service and through ENT, ear, nose and throat surgeons to get treatment. So in children, the first line of treatment for OSA is to take the tonsils and the adenoids out. And so what generally tends to happen is they'll see someone about their child's breathing, a pediatrician or their GP. Classically, some children will go straight to the ear, nose and throat surgeon, and they'll have very clear symptoms that would suggest that they need to have treatment. So they'll have their tonsils and adenoids taken out, and then they might be fine, and they might carry on just being monitored through the surgical service. For other children, they'll come through to someone like me, who's a sleep physician, and they'll be a little bit less sure whether they should go down the route of going into surgery straight away. And those are the ones in whom we would do a sleep study, and we would actually look and see whether they need to have treatment. And there's different ways in which you can treat. So first line is always to think about surgery because it's the most effective treatment we have. And then we think about things like using CPAP machines to help with breathing, which I'll talk a tiny bit about today. And of course, we monitor. There's also a group of children that have treatment and still have symptoms, and they're the ones that the ENT doctors, the ear, nose and throat surgeons, will send to us for us to do some more monitoring on. So you can see that this is kind of a little pathway that we follow quite regularly, and that children can go around in this pathway for several years, being monitored and then being referred when symptoms get worse, or if things get better, they might just be monitored for a period of time. Now, the important thing to know about a sleep study is it's not an easy test to know, and those of you that have been through this will know this already. Some children won't manage it at all. This is little Molly, and I'm very grateful to Helen for letting me use her photos. And this was Molly when she was younger, and this is her all hooked up, ready for her sleep study. And you can see there's a lot of monitoring on there. Sometimes we need to think about limited options, or sometimes we need to say, this is not going to work. We're going to have to go straight to treatment. The other important thing to remember is, of course, your child's going to be in a different setting. They're going to be in a sleep lab, and they don't necessarily sleep the way they sleep at home. So it's really important that we think about how we prepare them for the test as well. And of course, there is a chance that children get unwell, and frequently this is when we're trying to do studies. And so we need to try and find the period when the child's well to do the study so that we get an idea of the baseline breathing difficulties. We recently did a piece of work where we looked at all the children that came through the sleep lab, and we looked at children with typical development, and we looked at children with neurodisability. And what we found is that children with a neurodisability condition were 3 times less likely to tolerate the monitoring of the sleep lab compared to typically developing children. And importantly, it was actually children with Down syndrome who had the poorest toleration of all the leads and the setup. So we know that this isn't a perfect option. And just I wanted to share with you what we actually look at when we do a sleep study. So this is a lot of squiggly lines, but this is actually what we record through the night. So what you can see here is we record what we call EEG leads, which tells us about the stage of sleep. So this is on the head. We record some eye leads, which tell us again about the stage of sleep, and we have 2 different leads that are on. We record an ECG, so that's the heart rhythm, some respiratory bands, so we measure breathing effort from the breathing effort from the thorax, or from the chest, and from the abdomen. We also look at flow, so we have a little sensor that sits under the nose, and one that's like little nasal prongs that you see with oxygen. So we have 2 different ones that measure nasal flow and temperature change. We measure oxygen and carbon dioxide, and we also measure leads, which measure the muscle movement of the chin and around the diaphragm, which is just at the base of your chest. So you can see there's an awful lot of monitoring that goes on. This is what I see when I see a child who has really severe breathing difficulties and has quite significant OSA. So on this right side of the screen, what you'll see is these traces that are from the whole night. So you can see these big dips of blue, which is the dips in the oxygen saturations through the night. And that's telling us that this child was having problems with their breathing through the night. When we look at a screenshot of a window of around a couple of minutes, we can actually look at what's happening with the breathing. And what you see here with these blue shaded bits and then the pink is what we call breathing events. So these are apnea events where the child has had an obstruction to the top part of the airway. They've continued to try and breathe. So you can see that the bands that measure the breathing effort are continued, but the child has stopped breathing. There's no airflow coming in, and there's a desaturation there as well. So this is typically what I look at. And then what I do from this is I work out how severe the breathing problem is. For children with Down syndrome, sometimes they have a bit more complicated breathing. So they might have those obstructive episodes that I've mentioned where they can't get the air in, but they sometimes also have what we call central pauses where they stop breathing because the trigger from your brain to tell you to breathe doesn't function quite as well and can be a little bit sluggish at times. And so we see sometimes these red ones, which are these pauses where the breathing effort and the airflow has both stopped. And then we see mixed ones where you see a bit of both things going on. So this is the kind of thing that your doctor would be looking at when you have a sleep study. Commonly, this is what I'm actually faced with. So you can see here that it doesn't look as neat and tidy as the one I showed you before. So this is a child who hasn't really managed to keep the leads on the head. You can see that we haven't really got great traces here. And so often what I'm trying to do is work out what's going on with some of the information not recording very well because the child's really struggled. And this top bar here tells us about the child's sleep through the night. And you can see that there's lots of up and down, and that means the child was waking a lot through the night. So you can see that there's a problem sometimes with this monitoring. And just to put that into context, this is Molly's mum. So she's a parent and has been a nurse herself. And this was her experience of Molly having a sleep study. And she did say the hardest part was the nasal prongs and the thermistor, the ones around the nose. And trying to get her to sleep with the gear on was very challenging. So some of you will be aware that we have been looking at alternatives. So this is a mat that we've been testing. This is contactless, so there is no leads that go on the child whatsoever. It sits under the bed sheet, and what it does is it records movement and it records sound. So we can measure breath sounds, as you can see here, and you can see movement as well. And you can see these lines here look very similar to what I showed you on the other recording. This is the guy that invented this. So he's Colin Sullivan, who is a professor who also invented the CPAP machine, and I've been working closely with him. So the mat records sound and movement from the child underneath by being underneath them, and also room sound, so that we can see what's from the child and what's not from the child. We looked at this mat in children with Down syndrome, first of all, and we did a study, and we included 60 children with Down syndrome who came to the sleep lab for a sleep study, and we put the mat on at the same time. And what we showed was, there's a lot of information on this for those of you that want lots of information, but essentially what we showed is that the mat was actually really good at telling us if a child was likely to have sleep disordered breathing or obstruction with their breathing or not in this group of children. And we compared it directly to the result that we get on the sleep study. And in most cases, it was able to tell us whether the child was having mild, moderate, or severe obstruction with their breathing. So we were pretty happy with this. It was telling us that this could be a pretty good option for our children. We also looked at it in terms of what parents thought, and we published this in a paper just this year. And really, what we showed is that parents really felt this was pretty good, and that the Sonomat was actually a preferred method. And you can see some of the comments here. We got some really useful feedback as well about things that we needed to work on for the developers. But overall, families were really positive about the potential for this mat. So what we've been doing since then is that we've expanded this out. So we've been using it in a wider group of children with disability. And what we found is that with our preliminary results, and we're still analysing this data, but what we seem to be finding is that the MAT is pretty good in it can detect obstructive sleep apnea correctly in about 65% of patients. We also know that if you get a negative result on the MAT, then it's pretty good at telling us that the child doesn't have moderate to severe breathing difficulties. So we have the potential to use this as a screen. Could be the sort of thing that we say we get you to do at home first. And if it comes back as being okay, then that can put everyone's mind at rest and we might not need to go down the route of a study. But at the moment, we still need to do more to actually work out whether we can use this in a clinical setting. We're only using it in research at the moment, so it's not there yet. We need to look at whether it's going to be cost effective. Obviously, that's going to be really important. And there is a bit of technical skill in learning how to score these MAT studies. So we're trying to work on that so that clinicians can start using it with all the tools that they need. So we've got about 200 children at the moment that we're analysing data on. So hopefully this will be something that will come in the near future. So what about management? So I've sort of touched on this a little bit, but management is not different to what we do in typically developing children. We use what we call conservative measures, so things like weight loss, nasal steroids can be helpful sometimes in the short term, but really these measures are not always going to be helpful in a child with Down syndrome because the obstruction is often a little bit more complicated. As I've mentioned, taking the tonsils and the adenoids out is the mainstay of treatment. It's the first thing that we try and do. But we do know that children with Down syndrome have a higher complication rate, and often it is less successful in this population. There are other surgical techniques that people have thought about and people have tried, but we don't have enough good data to know whether these are really very useful or not. And it's very much now left to the surgeon as an individual decision as to whether they think there's a benefit for more surgery or not. My role is to think about things like CPAP or NIV therapy. So CPAP is continuous positive airway pressure. That's where you blow some air through a little nasal mask to keep the airway open at nighttime. And non-invasive therapy is one step up from that, where we use a bit more pressure and we use two pressures to help with the breathing at nighttime. There are some challenges with that, and I'll talk a little bit about that in a second. And there are some newer therapies that are being evaluated at present, and I'll talk a little bit about these as well. So when you look at outcomes after tonsils and adenoids, you definitely do see improvement. So overall, there is improvement in breathing after adenoids and tonsils are taken out in children with Down syndrome. So it is a good first-line treatment to use. What we do see is that the children that start with more severe OSA seem to be have the better improvement. So they have the larger improvement. And what's really important is that at least half of the children will still have some symptoms of breathing difficulty after having their tonsils and adenoids out. And unfortunately, we can't predict which children are going to be the one that are going to be left with the problems. So this is where we have to rely on, ensuring that we're following up and seeing what's happening after the surgery has been done. As I've mentioned, the management options for after adenoid tonsillectomy, you can use things like weight loss and steroid treatment for the nose. But if the child's still got moderate to severe breathing difficulty, they're not really going to be helpful. We can use CPAP, as I've mentioned, and there are further surgical options as well. So thinking about CPAP, one of the difficulties with CPAP is that, as I've mentioned, the face shape is slightly different in children with Down syndrome. And so the masks and the interfaces that we use can be quite challenging to fit sometimes. We try and use nasal masks. You can see Molly here with a nasal mask on. So the mouth is free, but the problem with that is that a lot of children with Down syndrome will breathe through their mouth and have a large tongue, and so a lot of the air will escape through the mouth. So sometimes we have to go to the full face mask as well. The CPAP will cause more air in the airway, and so as a result, you do sometimes see lots of secretions when you first start CPAP therapy, which can be quite distressing for children. And obviously, this is quite a big deal for a child, so it can be really difficult to get them to wear it. So we need to think about that, and we need to think about what we'll do if they won't manage. is there a support system at home to help the child? And we really do need to put quite a lot of work in to how we help children get used to this therapy. So in my practice, what we do is we do a lot of desensitization with the masks before at home. So we try and do that with the help of, if their children have their own occupational therapist, which most do, we try and work with them. We now have the luxury of having a sleep psychologist in our clinic. So we're starting to use her skills, and we are actually about to start a study in the research setting to try and see if we can work with families to really think about what will be helpful and what we could do to help with CPAP becoming easier for families to manage at home. But at the present time, it is still quite challenging for many families. That's not to say it can't be done. When it is done, it's done very well. So what else is there out there? Well, I just thought I'd mention a few things that are out there. Some people will have heard of high flow nasal cannula therapy. This is looks like little nasal prongs. Many children have this when they come in for an acute illness with an infection, for example. And this is something that we've been starting to look at in children who don't manage CPAP, as whether it's something that we could actually use at home. It could have the similar sorts of challenges. It's still something in the nose, so it's still likely to have some challenges for children, and cost could be a barrier because at the moment, there is quite a lot of consumables that need to be used with this that would be costly. We've also been looking at things called positional therapy devices. So some children, their obstruction is worse when they're on their back, and that's because the tongue flops backwards and crowds the airway more. So there are devices that cause some vibration and help you to alter your position. These haven't been tested in children at the moment, and we're about to start one of the first studies to look at this in children in our lab in Brisbane. Dentists and orthodontists are looking at things called splints or mandibular advancement splints. These are things that help to bring things forward during the night. They haven't been evaluated in children at this point in time, and particularly in children with Down syndrome, we don't have enough evidence and we don't have enough studies that have told us that we can use this as yet. A really exciting option that's coming around is something called hypoglossal nerve stimulation. So this is where we use an implanted device, and you can see here where it goes in. And what it does is it controls the nerve that controls the tongue, and it can push the tongue out during sleep. And this has actually been used in children in adolescence with Down syndrome in the US. The first study was actually done almost 10 years ago now in a child who had an index who had severe obstruction with their breathing. They wouldn't tolerate CPAP, and what this was able to do was reduce the obstruction right down to being really mild. So it was really quite exciting. Since then, that's actually been tried in a big trial, and there's a big clinical trial that's running at the moment in the US that's looking at this. And there are some trials starting in Australia in adult populations of, first of all, of typically developing adults, and then hopefully moving into adults with Down syndrome. So this is something that I think is going to come in time and could be a really nice option for older children and for adults. So key messages from an obstruction perspective. So from OSA, it's very much more common in children with Down syndrome, 6 times more common than in typically developing children. Lots of factors that contribute to the risk. It is often overlooked amongst families. Poor sleep isn't the norm, and you can ask for help. That's the message. For health professionals, we need to ensure that health professionals know when to refer, and also that they're not telling families that this is normal and that they don't need treatment for this. It's really important to treat obstruction particularly, but breathing problems in general. We know that children with Down syndrome who have untreated obstruction, their verbal skills, their speech skills are lower, their communication skills are worse, and they do find it more difficult to do day-to-day learning. So it's really important from that perspective. We know that a sleep study can be challenging. We are looking at alternatives, and definitely our service in Brisbane is trying really hard to find ways in which we can make this easier for families, and even try and do it at home if possible. And I think in terms of treatment, I think it's really important to know that it is complicated. We work really closely with the ear, nose and throat doctors. And we need to have, a really joined up management plan. And we are looking at the new options that are coming out on the horizon as well. So before I ended, I just want to spend a few minutes talking about non-breathing problems, so what we call non-respiratory sleep problems in children with Down syndrome, because I think it's really important, given that I showed you at the beginning that this is actually something that we see is really common in Australian children. So they can occur when you have a child who has a breathing problem as well, but they can also occur alone. Um, Children with Down syndrome have different sleep wake patterns. And one of the things that I think is really important to remember is that just like other bits of a child's development, sleep is actually developmental. So if a child is taking longer to walk or talk, then they're going to take longer for their sleep to become a normal pattern. So for their sleep to become a pattern where they sleep all through the night. And I think that's a really key message from me today, is that, you know, the expectation that you have for your child needs to be in keeping with their other milestones. So if they're not walking, if they're not talking yet, then the likelihood is that their sleep is also going to be more like an infant or a baby. So just bear that in mind. Intellectual disability does really sometimes make it harder to teach good sleep habits. So we need to think about the best way to teach those sleep habits. Obviously, children with Down syndrome sometimes, unfortunately, need lots of admissions to hospital. Parent stress can be really significant at times because of this and can really impact on getting a regular routine with sleep. And of course, there's often other health problems that are going on that need to take priority over sleep. So, you know, it does sometimes get overlooked or it gets sidelined because there's all these other things to think about. And then we know that children with Down syndrome sometimes have other conditions, such as thyroid problems, such as ADHD, that can really impact on their sleep as well. So we need to think about that when we're thinking about sleep. These are some quotes from some work we did where we talked to families, and some of you may have been part of this work. And it shows you just the real impact that sleep problems have on children with Down syndrome and their family members. So, you know, I think you can see here in the purple, I've put the quotes that sort of more speak to children. So we know that it causes more behavioral problems, more difficulties with their memory, difficulties in managing day to day, and an increase in ADHD-like symptoms. And then these quotes in blue tell you what parents have told us, you know, about how this has impacted on all aspects of their lives. So you can see there quotes about the whole household being awake, primary carers not being able to function, meaning that no one can function. Some things about personal, you know, life, destroying sex life, being really tired and not wanting to socialize, getting less sleep, so putting on more weight, low patience. I think these are all things that you'll probably be able to relate to better than I can. So when I talk to physicians, I talk to them about how to do this and how to make sure that they're assessing properly for non-breathing sleep problems in individuals with Down syndrome. I always tell them they need to ask about sleep because families won't mention it. This is a quote from one of our parents. We didn't reach out to anyone because we thought that was the norm. And we need to ask in a non-judgmental way. And you can see here two quotes that I've put up, one of which is quite disturbing. You know, we went to the pediatrician constantly. I was crying. I had a mental breakdown. He's not sleeping. He wouldn't believe us and would say that we just needed to treat him with dog commands. No family should go through this. And this is, you know, this is what I teach. And when I teach to clinicians is that you need to ask in a non-judgmental way, and you need to ask in the same way that you would ask other children. And we've published this work to really try and get the message out there that this is important. We talk about general sleep hygiene principles. So this is sort of general good sleep practices. So you want the child, an individual, to feel that the bedroom is somewhere they want to be. We need to make it a good environment, a positive environment for sleep. So having a dark and quiet bedroom, thinking about screen use, thinking about caffeine and sugar and the activities that a child might be doing before bedtime that might be stimulating rather than calming. We need to think about a good routine with a regular wake time and a regular sleep time. And we need to think about if there's lots of naps happening that could be in with nighttime sleep. So these are sort of general principles for everyone about sleep that we generally tend to talk about. But in children with Down syndrome and with additional different conditions, we always think about other things that we need to actually consider. So, for example, we need to think about, is a child hungry and that's why they might not be sleeping? Are they having trouble with their bowels? Are they not toileting properly? Are they hot? Are they having medicines that could be impacting? Do they have problems with their vision, with their hearing, with a physical impairment that might be making it difficult for them to get the right position? So these are all things that we talk about, being sure that we think about if a child with additional needs is struggling with sleep. I talk about the approach being like a stepladder approach. So you need to build things rather than trying to do a one quick fix. We need to think about what things we need to try and change and rank them from easiest to hardest, and then work with a family, work with a child to really work to their strengths to try and help them achieve this. And we talk about using social stories, visual schedules, and really tuning into what the child responds to. And of course, then looking at how we reinforce. So, making sure we do the same thing at the same time every day, looking at rewards, and rewards don't have to be, gifts. They can just be simple things like spending more time with the family, a family member that they like to spend time with, for example. We talk about breaking goals down into smaller, more achievable tasks, and then working towards a bigger task, and slowly working on exposing to new situations, building confidence using a strengths-based approach for the child, and breaking things down so that they feel more manageable rather than feeling like this big goal that we've got to try and achieve. In terms of how we look at helping families to create, for example, a bedtime routine, we give lots of options. So we think about why it's important, but we also talk about using things like social stories, visual schedules. Some children really respond to having pictures up, and looking at pictures of different parts of their bedtime routine and reminding them of what they've got to do at different times. Some like videos, some will respond to those rewards more. So really important for us to work with families and use some tools that make this a bit more manageable, but also can be tailored to an individual child. So my last key messages are that we need to remember that sleep problems in individuals with Down syndrome are underreported by families. They're overlooked and underdiagnosed by health professionals. And I'm working really hard with others to try and ensure we improve education and awareness, not just amongst health professionals, but also that families feel that they can really ask for help. In terms of breathing, OSA is very common regardless of age, and we need to promote lifelong surveillance. So this is something that we should be screening for, and we should be talking to families about all the time, and something that you should feel able to actually ask about at any stage. We know that monitoring for diagnosis and therapy is challenging, but we also need to ensure that we don't assume it's not possible. I have a number of children on CPAP therapy that are doing exceptionally well. So it isn't that it isn't possible. It is definitely possible. And I think we also need to remember that the non-respiratory, non-sleep breathing problems are also very common and need treatment. And I think most importantly that this is, the impact of not treating these sleep problems is very significant, and it has really significant negative impacts on function, health, well-being, and a huge impact on families, as I've hopefully shown you with some of my quotes today. So I'd like to thank you for listening. I'd like to thank you to the parents that have given me the pictures of their beautiful children that I can use in my talk, and for all the participants that have taken part in our study over the last few years as well. This is my puppy Ollie, who is hopefully yawning, but you're not yawning, and hopefully I haven't put you all to sleep. So thank you very much.
Thank you, Jazz. Great presentation, and thank you for sharing all that excellent information, and importantly for shining the light on, as what you say is what an often overlooked and underdiagnosed challenge, and also for sharing some great tips on how to improve sleep habits. I know I can personally attest that reward charts work very well for us to improve some of our sleep habits. We have about 15 minutes for questions. I've got a few questions come through already, but please feel free to post questions in the Q&A, and I will then put them through to Jazz. So we might kick off with the first question. And you touched on this a little bit, Jazz, but in the context of maybe an older adult with Down syndrome who's having difficulty with actually having a sleep test because of moving all the wires and everything, advice or words of wisdom?
Yeah, look, it's really challenging. And I think adult practice is a little bit ahead of where we are. So there are some alternatives that people have started to use in the adult space. Adults at this stage can also have studies done at home through public funding, which is something that we have just managed to get approved for children, but it will take another 6 to 12 months for us to actually be able to do that. But we're very excited that we were able to do that, and DSA were really supportive in that quest for us to be able to make that possible for families. So that's really exciting for us. It is difficult. Having a study at home sometimes can help, but obviously that puts the burden on the carer, so that's really challenging as well. To be honest, sometimes if you can't get a read because there's just so much, so much intolerance of the leads, which is very common, then sometimes the clinician needs to make a decision about whether the breathing is really the big problem or not. And that's the thing with a sleep study. It's really good for telling us about a breathing problem. It's not so good about telling us about other sleep problems that could be going on. So I think in this situation, it's worth having a discussion with the physician that's treating this individual and seeing whether they think this really is a breathing issue, and if it is, discussing what the options could be for treatment. And again, in adults, there are other treatments to CPAP. Things like the splints are possible. So that may be an option if they're not going to be able to tolerate something on their face. So that's one way of looking at it. But I think a discussion about what really is causing the sleep difficulty.
Excellent. Thank you for that one. We've got a question. Is it possible for central sleep apnea to improve in children?
Yeah, that's a really good question. So I didn't go into too much detail about that. So central sleep apnea is really the best way I like to explain this is that when we all go to sleep at night, we all have a little ticker that tells our brain to keep telling us to take breaths. And for some children, and particularly for children with neurodisability, we see that ticker is just not functioning quite the same way. It kind of goes breathe, breathe, whoops, breathe, breathe, whoops. And so you have these pauses with the breathing. Now, what we do know is that as children get older, that tends to get less. So we do see that children with Down syndrome may have quite a bit of that when they're younger. And then as they get older, it tends to improve. And so we think it's related to maturation of that breathing control. So yes, the answer to that question is that central sleep apnea can improve. We do see occasionally children in whom it doesn't improve and it stays there at a level all the way through that needs treatment. The treatment for central sleep apnea is different. You use oxygen usually as the treatment to try and help in that situation. But yes, on the whole, it tends to get better as children get older.
Excellent, thank you. Jumping back to one of your early points in the slides there where you spoke a little bit about parasomnias, including sleep talking. Specific question there from a lady who's got a daughter who's 24 and talks a lot during her sleep. Do you know in particular about any research on parasomnias, including sleep talking, that we could point in her direction? And happy to take this offline if you don't know off the top of your head, Jazz.
Yeah, look, actually, I don't think there is a lot, to be honest, because parasomnias is something that, although they can be quite troublesome for families, they don't generally, they're generally harmless. And actually, the individual often doesn't remember that they've had that happen through the night. So for the individual, they're actually still feeling and still do look like they go through and cycle with normal stages of sleep through the night. So there isn't a lot of research, as far as I'm aware, around parasomnias in particular for individuals with Down syndrome or in general, to be honest, because it's not an area that people get too concerned about. But what I do know is that there are the odd patient in whom the parasomnias are at a level where you feel that they do require some treatment, and so sometimes we use some medication for a short period of time to try and help resolve those. So again, you can talk to a physician about a particular treatment plan if it's bothering you in particular.
Excellent, thank you for that one. A question around oxygen saturation and whether that can be used alone as a kind of first step screening measure.
Yeah, that's a really good question because it's a really controversial question as well.
Okay.
So the answer to that question is, in the right hands, yes, it could. So you need to know what you're looking at. So as I've mentioned, individuals with Down syndrome have often got two different types of breathing problems. They've got the obstruction with their breathing sometimes, and then sometimes they also have the central breathing difficulties. The trouble with just looking at oxygen saturations is it doesn't tell you which type of breathing problem you have. So it doesn't help you to know what the right treatment is necessarily. But the way we actually use it is we use it to screen to see how much urgency there is to move to doing some treatment. So what we do in our lab, for example, is sometimes if we've got a wait for a sleep study, we might send an individual home with a monitor to do their oxygen saturations. If that comes back and looks like it's not too bad, then we know we've got a bit of time. It doesn't give us the answer, but it tells us that we've got a bit of time to play with and the child is safe. If it comes back and shows that there's lots of big deep dips in the oxygen level, then we would move quite quickly on to doing a sleep study because we know we need more information to direct the treatment.
Yeah, excellent. Thank you. A question around the frequency of sleep studies and whether that changes as a child becomes a teen and then into adulthood. This particular situation used to have yearly sleep studies.
Yeah, so the frequency is really variable. I would say that you have more in childhood than you do in adulthood. On average, when we looked at our population of children, we found that most children were having between 3 to 4 sleep studies during their childhood period. So we looked at children who'd been in our service for their whole childhood, and we found that on average it was about 3 or 4 during that period. And as you go into adulthood, generally that becomes less frequent. Now, there's probably a couple of reasons for that. One is maybe it falls off the radar a little bit, and that's a concern. But I think the other is that you have more ability to cope with a bit of obstruction as you get older than you do when you're younger. So what I mean by that is that you're more likely to have dips in your oxygen levels with a child who has obstruction than you are in an older person. So I think that's also a reason why there's probably a difference in how frequently you get monitored as an adult.
Brilliant, thank you. The next question is about sonomats, which sounds like a great device that should be available far more openly. You spoke in your presentation about the comparison of sonomats to having all of the leads, etc., on for children with Down syndrome. Has a similar comparison been done for children or adults without disabilities, and were the findings kind of in line?
Yeah, so we basically followed a study. So there was a series of studies done with typically developing children first, and those studies showed very similar results. So what it's basically showing us is that what we wanted to know was really, was this as good in a child with Down syndrome as it was in a typically developing child? Because we didn't want to assume that was the case, because sleep is different, and children with Down syndrome are usually a bit more restless. So we wanted to make sure that it wasn't going to have a problem with picking up breathing movements and things like that. And we found that it was actually very similar, and the results were very similar in both groups.
Excellent. Oh, that's good. Just need to get the funding to make it more widely available, hey?
I know, exactly. We're working on it.
That's right, absolutely. A question that again you touched on, I think, a little bit, is around one of the other potential surgical interventions. Someone just reflecting that they had a sleep specialist suggesting shaving the tongue. Is that something that you could talk a little bit about?
Yeah, so there is a surgery called tongue reduction surgery. So that is something that ENT doctors would generally consider. It is something that particularly in, I can only speak from the experience in Brisbane really, but I do know that our ENT doctors don't take that as something they do lightly. And the reason for that is that it obviously can impact on speech, it can impact on feeding. And so you really need to think about whether it's the right option and weigh it up with the potential risks associated with doing that procedure. That said, sometimes it can work very, very well. So there are children with different conditions who have, very large tongues, even bigger than, you know, what we see in some children with Down syndrome. For those children, that sometimes is the procedure that we do, and it can make a difference with obstruction with breathing, but you definitely have to weigh up the risks of what it could cause in terms of other problems. So that's why it's not something that's done as a routine. And I think, you know,
Sure.
I've seen occasionally that's the route that they've gone down, but it isn't without its challenges.
No, absolutely. A question around whether you can talk a little bit around myofunctional therapy and Vivos non-surgical solutions. Apparently, an airway dentist has recommended Vivos in particular.
So Vivos is not something I'm particularly familiar with, but myofunctional therapy is something that people, I guess it's coming into fashion a little bit now. People are thinking a little bit more about it. I would be very cautious with this. And, you know, I speak from the point of view of everything I use in my practice comes with lots of studies and evidence behind it as much as possible. At this stage, as far as I'm aware, in children in general, there is not a lot of evidence for the role of these therapies for breathing sleep difficulties in particular. There may be other benefits for other things that, you know, children might be dealing with, but in terms of looking at sleep breathing, there is not a good amount of data to tell us that this is something that really works. And so I'd be very cautious with that at this point in time. There are people looking at it in the US as a potential therapy, but I have to say that I'm a little bit skeptical at this stage as to whether it would have the benefit that we would want, particularly because we know that obstruction for children with Down syndrome has lots of different factors that play in that lead to them having this problem. And so I can't see how that would be, you know, a treatment that would work in its own right without something more for this more complicated condition in children with Down syndrome.
Yeah.
I could be wrong though, so we'll see.
No, great response. We might make this the last question. It's the last one we've got through at the moment. And it goes to that kind of broader diagnosis of, is this OSA or is this some other sleep hygiene type challenge? So particular example here around a team waking early, getting up and wandering around very early in the morning, like 4 or 5 a.m. Sleep apnea or something else, and how do you go about, you know, going down that path and working that out?
So generally speaking, something like that, to me, I would not think that would be sleep apnea related. So with sleep apnea, most of the time children will have, you know, very clear breathing difficulties that you will be able to hear or see. So if they're getting up and they're wandering around the room, that to me suggests it's more related to their if you like, their sleep-wake cycle, and potentially that could be also a parasomnia where they're actually not quite awake and they're actually still asleep and sleepwalking. So to me, that would suggest it's more a non-breathing related problem. And I'd say that you'd probably need to get more history to understand exactly what was going on and, you know a little bit more about what time the individual was going to bed. For example, adolescence can be really challenging because it is a time where sleep-wake cycles change anyway for everyone, and children tend to shift their sleep later. You know, we think it's all due to the fact that they start doing screens and all that kind of stuff, but actually there's an internal shift in your sleep-wake pattern at that time that makes you want to sleep later. So it is difficult because there's a lot of hormonal things going on that change sleep at that period of time as well. So I think it probably need a little bit more sort of working out as to what was the main factor that was causing that problem for that particular child.
Makes sense. Thank you, Jazz. We might leave it there with questions. Jazz, thank you so much for your presentation and for all the invaluable information you've shared tonight. Really, really appreciate your time and sharing your knowledge with your community. And more broadly, thank you for everything you do to support the Down syndrome community. It's fantastic. For those who are online, the recording of the webinar will be made available shortly and will be sent to everyone who registered, and Jazz has very kindly agreed to share her slides with everybody as well, so they will be sent out within the next few days. Thank you, Jazz.
Thanks, Daryl.
Thanks everybody for attending.